Hello, everyone. Thanks for joining us today. Just hold on a few more seconds. We're waiting for a few more people to have their computers load up and get ready to go. So thank you in advance for holding. Hello, everyone. We're just waiting for a few more folks to join us. I know it takes a few minutes for those computers to connect. So thank you in advance for holding. We'll start in about another 10 or 15 seconds. Good afternoon, everyone, and thank you for joining us for today's program. We have a few housekeeping items before we start today's program. I'm Andrea Jensen. I'm the education specialist for Allergy and Asthma Network and a certified asthma educator. All participants will be on mute for the webinar. We will record today's webinar and post it on our website within a few days. You can find all of our recorded webinars on our website at allergyasthmanetwork.org. Scroll down to the bottom of the page to find our recorded webinars and any upcoming webinars. The webinar will be 1 hour, and that includes time for questions. We'll take those questions at the end of the webinar, but you can put them in the Q&A tab at any time. The Q&A tab is on the lower left-hand side of your screen. Oftentimes we'll have people put questions in chat, and sometimes I'll miss those. So please use the Q&A tab. We have someone monitoring the chat if you have questions or need any help. We will get to as many questions as we can before we conclude today's webinar. We do offer CEUs for this webinar. This webinar is part of our series, Advances in Allergy and Asthma, in partnership with the American College of Allergy, Asthma, and Immunology. Allergy and Asthma Network offers CMEs for nurses and CRCEs for respiratory therapists. American College of Allergy, Asthma, and Immunology offers CMEs. You will receive an email a few days after the webinar. We will have links to all these resources so that you can get any of the continuing education credits that you need. We'll also have a link to the certificate of attendance, and we will also try to add that in the chat as we go along. Today, we're going to learn about food allergies, how biologics can bring hope. Allergy and Asthma Network is a grassroots organization that was started over 35 years ago by a mom who knew that other moms like her needed resources and support. Our mission is to end the needless death and suffering due to allergies, asthma, and related conditions through outreach, education, advocacy, and research. Today, it's my pleasure to introduce our speaker, Dr. Lindsey Moore. Dr. Moore has been in allergy practice in Norfolk, sorry about that, Virginia, for the last 6 years. She is an assistant professor of the Eastern Virginia Medical School in the Department of Pediatrics. She became a fellow of the American College of Allergy, Asthma, and Immunology in 2021 and serves on their food allergy committee and the CAP test writing committee member for the American Board of Allergy and Immunology. She is also active in asthma education within the American Academy of Pediatrics. Thank you for joining us today, Dr. Moore. Food allergies is always a hot topic with our listeners. We are glad to have you here to help our patients and providers learn more about food allergies and biologics.
Thank you so much, Andrea, for the introduction. I'm very excited to be here and to give this talk to you guys today about food allergies. So this is my disclosure slide. I do speak for Aimmune, which is a company that makes Palforzia, an oral immunotherapy product. We will be briefly talking about Palforzia today, but I don't believe my prior speaking engagements will cause any conflicts in today's presentation. And the rest of my disclosures are not relevant. So this is what we're going to cover today. I'd like to provide an overview of the prevalence of food allergy and the current management approach for what we do today. We're going to discuss key areas of focus in the future of food allergy management. We're going to review the pathophysiology of food allergy and what we call Th2 inflammation, which is really the center of all allergic diseases and not just food allergy. And hopefully, in explaining Th2 inflammation, you will see why biologic medications should work for food allergy. And then I will end with just some future perspectives and some food for thought moving forward. So let's get started. So studies estimating food allergy prevalence have varied, but the general consensus is that food allergy is rising. Now, the rates do vary depending on the geographic location that you live, as you can see in this image on the left hand of your screen. So the highest rates of food allergy are in North America, Europe, and Australia. And in North America, we can see rates up to 11%. Now, in the United States, we think that about 32 million Americans are dealing with food allergies. And this is based on data back in 2018 by Dr. Gupta. So it's estimated that about 1 in 10 adults suffer from food allergies and 1 in 13 children have a food allergy. So if you're listening to this and you yourself or your child doesn't have a food allergy, chances are if they're in school, your child has a friend that does. Now, food allergy management, this slide really goes over what we have been doing for this disease over the last few decades, minus the current decade, okay? And it's been relatively stagnant in the mainstream for a period of time. And I call this a mostly reactive approach to dealing with this problem. So typically what we see is we have a patient come to us with the history of a reaction. So hopefully it's a clear-cut reaction like IgE-mediated symptoms like hives or swelling, vomiting or trouble breathing immediately after ingesting a certain protein. And from there, we launch into our diagnostic testing. So we typically start with IgE testing, which in the allergy clinic is often skin prick testing. We also can do serum-specific IgE testing. But we know that this diagnostic testing has limitations. So both types of IgE testing are not good at distinguishing sensitization versus actual clinical reactivity. And we know that if you don't have the right history of a reaction, this testing can lead to a lot of false positives and misidentification. So ultimately, what we often end up needing to do is an oral food challenge where we try to feed the child the food in question and we see what happens. And this is the gold standard for diagnosing food allergy, but this procedure is time intensive, it's resource intensive. And so we're always looking for new ways to diagnose this disease. But once we do make the diagnosis of food allergy, we then teach people how to avoid their allergen. We teach them how to read labels, which seems straightforward, but as many of you on this video know, that label reading is not straightforward. Patients have to deal with precautionary labeling that says may contain or processed in a facility that contains their food allergen. And these statements are not regulated by the FDA, and it's hard to know what to make of them. And food manufacturers change their labeling all the time. We saw this recently with sesame. And so, yes, we still continue to teach label reading, but it can be very confusing. And then finally, we prepare our patients for, we teach them how to react when they're having a problem. So we prescribe auto-injectable epinephrine and antihistamines for mild reactions. And the good news is that epinephrine works great for allergic reactions, but you have to have it and you have to be willing to use it. And we know that there is hesitancy on the part of some patients to use it, and even among physicians, there's hesitancy to use it. So it'll be interesting to see in the future. We think that in the near future, a nasal epinephrine device will be released. And so hopefully that will, not that that will take the place of intramuscular epinephrine, but hopefully will prompt patients to use epinephrine earlier rather than later. Now, so this is, I think, where we have been for a long time, and I'm hoping to talk about where we are going. And I'd like to convince you why we need other approaches. So as I mentioned previously, the prevalence is continuing to rise. Accidental exposures are common. In a study back in 2018, Dr. Gupta found that 19% of food allergic children sought emergency room care for reactions within the last 12 months. and over 40% reported at least one lifetime severe reaction. 40% of children are not just avoiding one obscure food, they can have multiple food allergies, many of which are not outgrown. And in some cases, in particular, with cow's milk in young infants, we can see avoidance lead to nutritional deficiencies. And as I mentioned, label reading and avoidance out at restaurants, at social events, when you can't read the label, can be challenging. And many patients have significant impairment in their quality of life. And I think that's the most important point to why we are doing what we are doing to find other ways to deal with this. So this is just a cartoon of a large survey conducted back in 2020 of over 1,800 respondents, people that had food allergies themselves and parents with children with food allergies. And you can see that having a food allergy impacts many different facets of their life, whether it's the choice of where to send their child to school, how they can socialize with their friends, and 90% of respondents said it limits them from going to special occasions. We know that children are bullied more with food allergies and they can feel isolated. And so that's why this next slide I hopefully brings some hope. So again, these three facets of food allergy management are not going anywhere, but I'd like to talk about two new categories. So prevention. So over the last, I'd say 10 years, we've been talking a lot more about preventing this problem from even happening. So the landmark LEAP trial, which was published in 2015, taught us that early introduction of peanut decreases the risk of developing peanut by 80%, at least in high-risk infants. Other studies have said this rings true for other foods. The data is not as robust, but still likely holds true for egg. And in 2021, in Jackie, there was an article published that early introduction of cow's milk formula between 1 to 2 months can decrease the incidence of cow's milk allergy at 6 months. But early allergen introduction is not the whole picture, and we know that based on what we saw happening in Australia. So in Australia, through these amazing public health outreach programs that got the word out to parents that all babies needed to have highly allergenic foods introduced in their diet, they found that in 2018 to 2019, 88% of Australian parents reported that they had introduced peanut into their infants' diets by 1 year of life, compared to about 28% in 2007 and 2011. But unfortunately, there wasn't a significant change in the prevalence of peanut allergy, even though they made these great strides. So it was really disappointing. They came up with some reasons why, but the point is it's not just one thing. We do know that the skin barrier, protecting the skin barrier is very important, as atopic dermatitis, particularly when severe, when prolonged, and very early in onset, is a major risk factor for food allergy. And studies looking at children with eczema have shown us that children with eczema even have transepidermal water loss, which is a hallmark of the disease, as early as 1 week of life, even in healthy appearing skin. And so this PEBBLE study is looking at whether if we are aggressive with skin barrier protection early on, maybe this will help prevent food allergy. We're looking at vitamin D as a preventative measure, even the BCG vaccine, which is thought to be a microbial stimulant of the immune system, shifting away from Th2 inflammation, which is allergic inflammation, to Th1. And then finally, biologics as disease modifiers. So biologics as disease modifiers is an important point, and I think this is going to evolve over time. So the atopic march was described 20 years ago by observation, but it's been confirmed in prospective trials, evolving to the progression of atopic dermatitis to other allergic conditions like asthma, allergic rhinitis, food allergy, and eosinophilic esophagitis in a non-linear fashion. And not everybody gets all allergic diseases. But a recent meta-analysis in Jackie in Practice found that dupilumab, which is a biologic agent, can reduce the risk of new or worsening allergic events. And this is whole categories of allergic diseases like asthma, allergic rhinitis, and it can potentially reduce it by 34%. So perhaps now that we are seeing Dupixent being started in younger infants as early as 6 months, maybe this will impact whether that child goes on to develop not only food allergy, but potentially asthma as well. And another important one is viral infections. So since viral infections can potentiate allergic Th2 responses, and circulating IgE, the allergy antibody, can impair the way we deal with our viral responses. Perhaps if we block IgE, we could prevent asthma down the road. And so there's a trial going on with that, which I know doesn't have to do with food allergy, but the PARC trial is a multi-center trial looking at omalizumab versus placebo in 2 to 3-year-old wheezers and whether this affects asthma down the road. So there's a lot going on, and hopefully some of these biologic agents can help us later down the road, even before we're dealing with the problem. Now, the other category that we're going to spend the bulk of the presentation on is treatment strategies. So we're going to be talking about oral immunotherapy. And while we're not talking about these other forms, I'd like you to know that other forms of immunotherapy are being studied and done in some private practices. So we have sublingual immunotherapy, epicutaneous immunotherapy, the patch is still being studied. We'll talk about biologic agents, but there's a whole host of other topics being researched right now in the treatment of food allergy. So lots to look forward to. Okay, so a few slides on oral immunotherapy, because we're going to talk about this in conjunction with the biologics. So oral immunotherapy is a desensitization therapy aiming to increase the threshold of dose that triggers an allergic reaction. Now, the image on the top right of your screen shows the general procedure that's done in research settings. Typically, you start out with a food challenge to confirm you're allergic, and this is followed by several weeks of updosing where a patient comes in and sees the physician and gets a slightly higher dose of the food they're allergic to. And this continues until they get to a top maintenance dose, which is then continued daily at home until a period of time. Often in research trials, they will then stop the daily dose and then retry the food a period of time later to assess for something called sustained unresponsiveness. You can see down on the right that the doses that are used for oral immunotherapy vary. Palforzia, which is the OIT treatment product for children ages 4 through 17, is listed on the top line. And then on the bottom line is the range of doses that I found that's been used in private practice. So there's a wide range. Some key definitions that we often throw around when we talk about oral immunotherapy is desensitization, which is a temporary state of clinical non-reactivity dependent upon persistent allergen exposure. Sustained unresponsiveness, which basically means that a food can be consumed safely without any treatment, even after a period of time where one abstains from eating the food. And then the less technical term, bite-proof, the ability to tolerate small trace amounts of the food without a significant reaction. And in 2018, there was a modeling study done by Schreffler in the Annals, which suggested that if you can increase the baseline threshold from 100 milligrams or less of peanut protein to 300 milligrams of peanut protein with immunotherapy, that this will reduce the risk of experiencing an allergic reaction by 95% or greater for all 4 packaged food products. So getting somebody to that point, you could then call them bite-proof. So they're not out eating peanut butter sandwiches, but they feel safer and they're not as worried about that precautionary labeling that I mentioned. Now, OIT has limitations and disadvantages that are worth noting. We know that safety remains a concern. 80% of subjects that undergo OIT experience adverse events. Now, most of these are mild, but anaphylaxis can occur. In the Palisades trial for Palforzia, 14% of patients experienced anaphylaxis. There were no deaths. And estimates of incidence of EOE, or eosinophilic esophagitis, vary. So we think that this can be a side effect of oral immunotherapy, and the estimates range from a little under 3% to 14%. We know that long-term adherence is an issue, like any therapy where we tell somebody, hey, you have to do this daily for an undetermined period of time, perhaps indefinitely. Of course, adherence is going to be an issue with that. And there is actually conflicting data on whether OIT improves quality of life. And we must remember that at this point, OIT is really meant to desensitize, not to cure. I mean, we would love for it to cure, but the fact of the matter is, for most of the studies we've seen so far, we are looking to raise that threshold dose. But as you can see in the background, the allergy is still there. So it is not a cure for the food allergy at this point. Now, transitioning to biologics. So what is a biologic? A biologic medicine is a medicine made from cells of a living organism. In allergic diseases, biologic medications can target antibodies, inflammatory molecules, or cell receptors, which thereby block inflammatory pathways. And this is a very busy cartoon, but it illustrates all of the inflammation going on under the surface of a barrier. And in the red boxes are different biologics and where they work. So allergy is associated with a breakdown of tolerance that promotes antigen sensitization. So what happens is there is some type of injury or stress to an epithelium, and the epithelium secretes cytokines known as alarmins up here, IL-25, IL-33, and TSLP. And that basically warns the immune system that there's a problem, and these promote what we call Th2 inflammation or allergic inflammation. If this person is going on to develop food allergy, the dendritic cell, which is a sentry cell, will sample the food allergen, and in the context of seeing these alarm signals, they will then further tell T cells to secrete more allergic signals, which in turn cause the B cell to make IgE. So the main biologics that we're going to be talking about today are ones that interfere with IgE on the B cells. We'll talk briefly about a drug that blocks interleukin 33, and we will talk a little bit about dupilumab today. Now, in general, before we get into the specifics, I'd like to highlight some advantages and disadvantages of biologics for food allergy. So that previous slide showed you what happens in allergic inflammation. Again, this is not specific to food allergy. This happens with allergic rhinitis. The dendritic cell samples the ragweed pollen just as it samples the peanut protein, just at a different epithelial surface. And so a biologic should be able to treat comorbid conditions. If you have asthma, if you have allergic rhinitis and you're on a biologic for food allergy, it should help all of those different conditions. It is also antigen non-specific. So if you are somebody with multiple food allergies, the biologic doesn't just attack the peanut IgE. It can bind to the wheat IgE, the egg IgE, the ragweed IgE. The safety of the products themselves versus imparting safety as an adjunct. So what I mean by that is we have a lot of experience with biologics. Omalizumab has been around for the longest. And we know that there are safe medicines, and they can also help make other treatments safer, like oral immunotherapy. And I will show you some of the studies which show that. They are intermittently dosed, so not something you have to do every day like oral immunotherapy. And as we discussed on one of the first few slides, maybe they will interrupt the atopic march. The disadvantage of biologics, definitely the cost is going to be an issue. These are pricey medicines. We don't know how long we'd have to have somebody on these treatments. So what we think so far in treating other allergic disease with these biologics is they really only work while you're doing them. So it'll be important to determine how long we need to have patients on these, and so we can properly counsel them. And then I put injection site reactions on there, and I'm not sure this is a huge deal for adults, but for children, for a little 1-year-old baby, giving them a shot every 2 weeks is not ideal, right? So the fact that most of them are injectables, I would say, is a disadvantage. So let's get into some of the studies. So omalizumab is by far the most well-studied for food allergies. So omalizumab so far is currently FDA approved for moderate to severe asthma in patients greater or equal to 6, chronic spontaneous urticaria in 12-year-olds and up, nasal polyps in greater than 18-year-olds and up. The mechanism of action is Xolair binds to IgE, the IgE receptor on the surface of mast cells and basophils. And this in turn down-regulates the FcER1, which is the receptor for IgE on the surface. And then it reduces the blood levels of free IgE. Now, this is the first study we're going to discuss. So this was done in 2019. This was just an observational study, but I found it fascinating because this was done in patients with severe persistent asthma who we usually stray away from in doing food challenges. So this was a really interesting study. So it was 15 patients between the ages of 8 and 23, and these were all subjects with a history of more than 2 food reactions or 1 food reaction, and they also would have had, if they only had 1 food reaction, they would have also had to have failed oral immunotherapy. The researchers did an open food challenge, so it was not blinded, so that can introduce some bias at baseline and then 4 to 6 months after omalizumab. There were 23 food challenges conducted in 15 patients. And I will say these weren't all highly sensitive patients, but the good thing is even if they weren't highly sensitive, you still saw a before and after using omalizumab. So as you can see, there was a large increase in threshold. So overall, a mean increase in threshold from around 1,013 milligrams of protein to 8,727 milligrams of protein. And again, antigen non-specific. So children with wheat, egg, milk, and baked milk all had an improvement in their threshold. 70% of foods tested after this period of time on omalizumab were tolerated, and that was at a full serving. And patients did report that the number of reactions to unintended ingestion while they were on omalizumab dropped from 47 to 2. The study also found an improvement in quality of life. So the takeaway is that the food allergen threshold of these patients increased 8.6 times its original value with only 4 to 6 months of omalizumab. This study was published in JACI in 2012. It's titled Kinetics of Mast Cell Basophil in Oral Food Challenge Responses in Omalizumab-Treated Adults with Peanut Allergy. So another small study of 14 patients, all had blinded, double-blind placebo-controlled trial prior to the study, and these patients were on omalizumab every 2 to 4 weeks for 6 months. And what the researchers did here was they monitored basophil hyperreactivity, and when the subject's basophil hyperreactivity was reduced by 80%, they did a second food challenge. And then they did another food challenge after being on omalizumab for a full 6 months. Now, as you can see here, the group really split as far as to how they responded to omalizumab. So you have this one group that responded dramatically after a short period of time, and then one group that didn't do as well. And there wasn't a huge difference between the second food challenge and the third food challenge. It's almost like they declared themselves quickly. But among all subjects, the median threshold dose of peanut protein was 80 milligrams, and this increased to 6,500 milligrams at the second food challenge. So a median 56-fold increase in the amount of peanut protein that they were able to tolerate. And I do want to make a point that, you can look at this and say, wow, these people really didn't get much better. But when you start at 80 milligrams, even in the worst case scenario, these patients were getting to around 1,000 milligrams, which if we go back to the concept of bite proof, 1,000 milligrams of peanut protein is 3 peanuts. That's well past bite proof. So that may be very clinically meaningful for some patients. There were a few other small studies using omalizumab as monotherapy, but instead of explaining all of those, I pulled this recent meta-analysis from JACI in Practice. And this included 4 studies, 210 patients. And similar to what we showed in the last 2 slides, this also agreed that in all studies, there was a treatment effect. And omalizumab significantly increased the tolerated dose of multiple foods versus pre-omalizumab over a period of 17 to 22 weeks. Not all studies were significant, but all showed a treatment effect favoring omalizumab. Additionally, omalizumab monotherapy for 17 weeks significantly improved quality of life from both patient and parent perspectives compared to pre-omalizumab. Now, these studies were heterogeneous. There were different quality of life measurements, but nonetheless, they all showed an effect. Now, switching gears briefly from omalizumab, this is a phase 2A safety study for itolizumab, which is directed against IL-33. Remember, that's one of those alarmin cytokines secreted when there's a breach in the epithelium, and which then mediates B-class switching to IgE. This was a study done at Stanford. It was another small study, 20 people with peanut allergy, all adult patients that were confirmed peanut allergic by food challenge. And 15 patients got the drug and 5 patients got placebo. And they only gave them 1 injection. And they wanted to see after 1 injection if they could tolerate a cumulative dose of about 275 milligrams of peanut protein. And this was a very short study. And you can see only after 2 weeks, 73% of patients receiving the drug were able to tolerate the dose versus 0 of placebo. And at day 45, that protection seemed to wear off a bit, and 57% were able to tolerate the 275 milligram dose. Compared to placebo, the itolizumab group also experienced fewer moderate adverse events during the food challenge. So this was a short study, a short follow-up period, a small sample size, but again, evidence that these biologic agents can work quickly and somewhat effectively, almost a full peanut just after 2 weeks. Now, I don't have any data to present on dupilumab, but I will, in a few slides later, tell you about a study that's the results are pending. But I just wanted to review that dupilumab is currently approved for several allergic conditions. So severe persistent asthma down to 6, atopic dermatitis down to 6 months, eosinophilic esophagitis, chronic rhinosinusitis with nasal polyps, and I think the other one that we don't treat is prurigo nodularis. The way dupilumab works is it binds to the interleukin-4 alpha subunit on the receptor, and it inhibits IL-4 and IL-13. And the reason that's important in food allergy is because this prevents the B cells from differentiating into plasma cells and making more IgE. This was just a letter in the this was a letter in the Allergy Journal in 2022, which showed the effect of dupilumab on serum IgE levels in patients with moderate to severe AD with comorbid food allergy. And as you can see across all foods, there was a pretty substantial drop in IgE levels. The peanut levels dropped by about 53%. Walnut, after 3 years on dupilumab, dropped 80%. Now, there were no challenges associated with this, and just because your IgE level has dropped does not mean you can tolerate a food, but it is interesting and promising that dupilumab will hopefully in the future play a role in food allergy. All right, so biologics plus oral immunotherapy for food allergy. So in the interest of time, I'm going to go through this fairly quickly. So to oversimplify our complicated immune system, we have naive T cells that can really grow up to be anything they want. They can grow into Th1 cells, which do something called cell-mediated immunity, Th2 cells, which make antibodies and allergy antibodies, Th17 cells, which are more active in autoimmune disease, and then T regulatory cells, which help keep the peace, keep the balance. So we think that OIT induces these T regulatory cells, which helps suppress the allergic response and repolarize things back to the middle, back towards the Th1 side, and make a different antibody than IgE. They can help make IgG4, which is a more tolerating antibody. Now, omalizumab, in conjunction with OIT, can make an IgE and anti-IgE antibody complex which then downregulates the receptors of IgE, and this together is what makes this combination, we think, effective. So this study was known as the PROTECT trial. It was the first randomized double-blind placebo-controlled trial, multi-center, looking at omalizumab in conjunction with peanut OIT. So all patients underwent the double-blind placebo-controlled trial. This was 37 patients, 3-to-1 omalizumab to placebo. And you'll see in all these studies that do both, that there usually is a period in the beginning where they just get omalizumab, and then after a period of 12 to 16 weeks, they start the oral immunotherapy. So in this study, they started omalizumab or placebo, and then at week 12, they started oral immunotherapy. And then their primary outcome was to see whether the patient could tolerate 2,000 milligrams of peanut protein 6 weeks after stopping OIT, while they were still on oral immunotherapy. And then they also saw whether a patient could then tolerate 4 grams of peanut protein 12 weeks after stopping omalizumab. And these are the results. So omalizumab pretreatment allowed 23 out of 29 subjects to tolerate 250 milligrams of peanut protein, which was actually cumulatively 490 milligrams on day 1 versus 1 out of 8 of placebo. And the graph on the top depicts that. So that's day 1. And that's pretty remarkable. So if you think about Palforzia, the top dose that you get at the end of the protocol is 300 milligrams. And that's not after 6 months of escalating. So with this omalizumab pretreatment, they were actually able to get to a cumulative dose of 490 on day 1 of starting OIT. So it enabled them to do a very rapid desensitization. 79% of omalizumab treated patients were able to tolerate 2,000 milligrams 6 weeks after stopping omalizumab. So as long as you maintained the oral immunotherapy, most patients were able to tolerate the 2,000 milligram dose as well as the 4,000 milligram dose. I do want to bring up a potential concern that they found in this study. So 6 of the 22 omalizumab treated subjects who passed the 4-gram challenge at week 31 had to reduce their dose at some point over the following 20 weeks. Because at that point, the omalizumab, really had worn out of their system. Now, they still were able to tolerate at least 2 grams. So they didn't lose all protection, and they still, in fact, were protected to a large amount of peanut protein. But there is that thought that as we stop omalizumab, what somebody is able to tolerate at one point might not always be the same. This trial, again, similar design, but much longer, was a randomized double-blind placebo-controlled study of omalizumab combined with OIT for the treatment of cow's milk allergy. So they started off with omalizumab or placebo for 16 weeks, and then they started the milk OIT, and they did this for a very long time. So 64 weeks on drug, which was blinded, and then an extra year on the drug, with maintenance OIT the entire time. At week 112, they stopped omalizumab, and then they did a 10-gram food challenge to milk. And just for reference, 1 cup of cow's milk is about 8 grams, so a little over a cup of milk. And if the patient passed that challenge, they continued on 8 weeks of oral immunotherapy, then they stopped it, and then they challenged them again to assess for sustained unresponsiveness. So the hope was that maybe in doing Xolair and OIT for a long period of time, we can stop all this and move on with life, right? And here are the outcomes. So if you just did milk OIT and not milk OIT and Xolair, you still got to maintenance. Most of them did. So 26 out of 29 milk OIT alone reached the maintenance, which was about 3.8 grams. And 27 of 28 of the omalizumab plus milk OIT reached the maintenance. But they did find that if you got omalizumab, your escalation phase was about a month shorter. And at the time of the food challenge, 88% of omalizumab passed versus 71% of the OIT alone group. And sadly, when we stopped OIT for 2 months, both groups dropped in their ability to tolerate that milk dose. So only 48% of the omalizumab group passed that 10-gram challenge after 2 months off OIT versus the 36% that received the placebo. There were also less adverse reactions during the escalation phase in the omalizumab group. So the takeaway point here is that omalizumab with OIT showed significant improvement in measurements of safety, but not in outcomes of efficacy with milk OIT alone. We mentioned that many kids have multiple food allergies. So can this work with multiple food allergies? So this was a study conducted at Stanford, the shortest pretreatment time yet. So 8 weeks of omalizumab or placebo, and then starting OIT. And they did up to 5 foods of oral immunotherapy. And then they stopped OIT after 6 weeks, just kept the patients on OIT, and then did a food challenge. And you can see on the right, these were all the foods that were included in various patients' OIT. The primary endpoint was the proportion of participants who passed the food challenge to at least 2 of their offending foods. And as you can see, the omalizumab arm did better. So 83% of the omalizumab group passed their 2-gram food challenge for at least 2 foods versus 33% of the placebo. They also looked at safety and found that GI side effects were not prevented with omalizumab. However, again, decreased in frequency compared to just those that were doing OIT alone, 22% with omalizumab versus 54% of placebo, which occurred especially in that escalation phase. So the conclusion for this study is that omalizumab in multi-food allergic patients improves the efficacy of multi-food OIT and can enable safe and rapid desensitization. And this is my last study that I will show you. And this study was interesting because this really tested, again, sustained unresponsiveness. So they started out here, open label, everybody got omalizumab, and then everybody was put on OIT for multiple foods. But then at week 30, they did a food challenge. And if you got to a certain dose, you were able to then continue 1,000 milligrams of your food allergen daily, or 300 milligrams daily, or stop. And then they assessed whether you still were able to pass your food challenge. Now, it was interesting that if you got 1,000 milligrams or 300 milligrams a day, it didn't really matter. But taking that together was definitely more efficacious in passing your 36-week food challenge than if you stopped OIT. So again, it would be nice to think we could do Xolair, we could do OIT and then stop, but it seems like we lose protection over time if we don't continue at least OIT if you're stopping the Xolair. Now, this is a large trial. Just check the time here for a second. Okay, we've got about 15 more minutes. So this is an ongoing trial that I think when it's concluded will really set the stage for whether omalizumab is approved with a food allergy diagnosis. So this is a prospective phase 3 study investigating safety and efficacy of omalizumab in patients down to age 1 up through 55 with peanut allergy and at least 2 other food allergens. So milk, egg, wheat, cashew, hazelnut, or walnut. Now, there are 3 stages to this study. They're looking again at monotherapy of omalizumab for 16 weeks versus placebo. And then they're looking at omalizumab plus multi-allergen OIT versus placebo OIT. And then the really interesting stage, which is stage 3, is assessing for the ability to switch to real-life foods and how that works. So I'm really excited to see the results of this study. Omalizumab, again, is not the only drug still being studied. On the right, you can see there are a lot of other ongoing clinical trials. The dupilumab as monotherapy has results that are pending. This is a phase 2 study looking at peanut allergy. We have ligalizumab, which is in phase 3 trials, which is another anti-IgE like Xolair that actually has a higher binding affinity for free IgE than omalizumab. So this is looking at monotherapy for ages 6 through 55 with patients with peanut allergy. And then lastly, I wanted to mention the combined study. So this is a phase 2 study looking at sequential use of omalizumab and or dupilumab during multi-allergen OIT. So there's just, the sky is the limit for these studies. There's going to be a lot more studies coming out for food allergy indications. So some considerations moving forward. So I like to ask myself when I'm reading these studies is, what are the outcomes we're trying to measure? So most studies focus on, can we get somebody desensitized? Can we get sustained unresponsiveness? And what are the adverse events? But there's significant heterogeneity in how each of these measures is defined. And even anaphylaxis can be defined differently in different studies. And so we really want to be thinking about what patients care about. What are those intangible endpoints that matter to them? How would omalizumab affect their quality of life? How would it affect them eating peanut in the real world? The double-blind placebo-controlled trial in the real world. What does that look like for patients? And so that's why I'm really excited about Outmatch, because it seems like they're incorporating these real foods into the trial to really help better advise patients on what this means for them in their day-to-day. And we also have to ask ourselves, what are the goals and motivations of families that are pursuing these treatments? So this was a survey done via social media platforms and food allergy listservs. So probably not representative of all patients with food allergies, but these were all parents who had pursued OIT for their kids. And this survey asked them what was their primary goal of OIT, and 62% said reduce the risk of a fatal food reaction. 10% said reduce the hassle of strict avoidance. 9% said I'd like to be able to incorporate the food into the diet normally. And taken one step further, they were asked to quantify what they thought the actual risk of death from a food reaction before undergoing OIT was. And 35% felt the risk was about 1 in 1,000 that their child could die from the food allergy, and 23% thought that the risk was about 1 in 10,000. And we know that those are far inflated numbers and that food allergy deaths are actually very rare. A study done, I believe in 2016, said that fatal food anaphylaxis in people with food allergy has an incidence of about 1.8 per million person years. So, we're doing these studies, but we really just need to be talking to our patients and, reassuring them that doing OIT is not going to change the risk of fatality, because the risk of fatality is already so low. Now, can these treatments help reduce the hassle of strict avoidance? Absolutely. But again, what are your motivations for doing this? And let's be transparent about why we're doing this. And again, most families would not consider in the survey, most families would not consider OIT a success if the food could be included in the diet, but they had more reactions. And we know that in doing oral immunotherapy, you are going to have reactions. So again, just conversations with the families are so important. And I think presenting this to them, that there are still logistical issues and unanswered questions, helps them frame their decision better on whether they want to pursue this type of treatment. So we don't know when to stop biologics. We don't know the optimal dosing of biologics right now. How much, how often. Now we do have studies that are ongoing for that. There's a trial called the BOOM trial, which is looking at how we should be dosing omalizumab, just by weight, by IgE. So hopefully we'll have some more information on that. We don't know the optimal dosing of OIT. What maintenance dose is best? Is too high of a dose going to induce more EOE and side effects and be harder to be adherent to? Where's that sweet spot for maintenance? What's the acceptable cost of doing business? How do we make these medications affordable to those that can't afford them? And then are there long-term risks of biologics and OIT that we're just not considering? In conclusion, The management of food allergy is evolving and will ultimately give patients more treatment options for consideration. Many of the treatments available in the near future will be time-intensive, costly, and will require long-term commitment on behalf of the patient and medical staff. It is of the utmost importance to be transparent about the risks and benefits, acknowledge the gaps in our knowledge, and identify the patient goals prior to starting treatment. And with that, I thank you for your time. I hope you guys enjoyed it and learned something.
Thank you, Dr. Moore. That was a lot of great information. And I particularly like one of the comments that you made at the very end here. There's sort of that fear about food allergies that, one bite and one of us could pass away. And I'm including myself in that. I also have food allergies. But you mentioned that it's 1.8 per million that will have food allergy deaths. Is that correct?
Yes, per person
Okay.
years.
Okay. So really your webinars really bring a lot of hope, I think, is what I'm getting out of this for a lot of people. So thank you for that. And we'll go through a few of these questions here. This first one's a little bit long, so hang on with me. It says pediatricians and allergists are encouraged early introduction of allergens, specifically peanuts, but I would want to caution we wouldn't be giving peanuts to an infant. We would be using peanut powder or peanut puffs or something. But then they say based on the LEAP study. However, the LEAP study was based on children receiving 2 milligrams of peanut 3 times a week until 5.
Andrea, can I pause you
Yes.
for 1 second? I'm sorry, I have an
Yes.
emergency on the phone. I'm so sorry. 1 second.
That's okay. You go ahead and take that. And for everyone that's listening with us, we'll wait till she hops back on the line. Chris has been great to be able to put some things in the chat here. So for those of you that joined us a little bit late, this is a credentialed webinar. We have different series that we offer. This particular series is with the American College of Allergy, Asthma, and Immunology. So since this is credentialed, we're not able to share the slides, but this will be on our website, this recorded webinar, within a few days. So you will also get an email from Zoom, a little follow-up webinar, or follow-up email, excuse me. On that will be links to our website. If you are a nurse, you can get CNEs from us. You can get CRCEs as a respiratory therapist. And then there will be a link to the website for the college where you can get a CME. So just know that that will be available for you. And that's pretty quick. It's within a couple of days. And I know that she's on the phone and that's what happens. Sometimes with our clinicians, they get called away on emergencies. Let's see, let me just check the chat here and see if there's anything else. Great information on biologics, lots of thanks from people. We've got people.
I'm so sorry, I'm back.
Okay.
My child got hit with a baseball in the eye. So
okay. Well, that's yeah.
It'll be okay. It'll be okay. So so the question about peanut introduction, do you want to repeat that question?
Yes. And it says pediatricians and allergists are encouraging early introduction of allergens, specifically peanuts or a peanut product. We should clarify it need to be a peanut powder for an infant based on the LEAP study. However, LEAP study was based on children receiving 2 milligrams of peanut 3 times a week until they were 5 years old. So what they're also asking is there data suggesting if the child is given less, is this still helpful? What if the family has a child with a peanut allergy and they need to introduce the allergen to younger siblings? We know a lot of parents are really nervous about that. So the final part of the question, does any amount of allergen help prevent allergy, or can infrequent exposure cause allergy? A lot of different points to that question.
Yeah, I of course don't know the sweet spot. We think that the 2 teaspoons 3 times a week is definitely enough to prevent the problem. If you are giving a little bit less of that, can you still prevent the problem? Probably. But if you are giving it infrequently in very small amounts, that may not be enough to prevent it if you are kind of genetically predisposed anyways to go on and develop the allergy. So we have had patients where we feed them peanut in a food challenge, they pass and they don't continue it regularly and they still go on to develop the allergy. So where that sweet spot is, that's just enough, I don't know, but there is such a thing as too little and not often enough. as far as if you have one child that has a food allergy and you're trying to introduce it to the other, I still think you can do that. You just need to, maybe do it when the other one is napping. Make sure you're washing hands with soap and water to get the food off your hands, making sure they're not sharing cups. But it's just too important to introduce it than to just avoid it because your other child has the allergy.
Okay, yes, lots to unpack in that question, and
Yeah.
thank you for all of that. Thank you. There's another question here. It says there's a company in California who uses a gradual introduction to allergen exposure with specific dosing amounts for the individual instead of a set dose like OIT. Why is this type of therapy not being further examined by the FDA?
I'm not sure about that company in California. So I don't know that the FDA needs to do that. I think the point is that we need to get across that foods that are common allergens need to be introduced early. So, and we don't want to medicalize feeding food. We don't want to say you have to feed this amount, on a Monday and this amount on a Tuesday. We still want it to be fun. It just needs to be a varied diet, and early enough while the immune system is still developing. So I don't know why the FDA is studying that, but I'm hopeful that we still keep eating fun and not so regimented.
Right, right. And that's a great point too. A lot of us have food allergies, have a little bit of fear, but we need to be able to enjoy our meals and with our family members. So glad you mentioned that. Thank you. Let's see, we have another question, and it says, although most studies are based on peanut allergy, would it be possible that if any of these biologics were successful to incorporate the allergen into the diet, could it be used for multiple food allergens?
Yes, definitely. As we talked about, these biologics are not specific to peanut. A lot of the studies focus on peanut, I think, because it's common and it's often not outgrown, but it should work for any food allergen.
Great, great. And that's one thing I noticed when you were talking about IgE, because I'm hopeful that down the road I can use that for a seafood allergy that I
Yeah,
have myself. So,
right.
what symptoms do the patients experience when on biologic treatment, and how do families manage the symptoms?
So the side effect profiles are really good. We have, with Xolair, we used to be worried about anaphylaxis, but it's a very low rate of anaphylaxis with Xolair. Almost all the biologics now can be given at home, which speaks to their safety. Dupilumab, we always monitor for conjunctivitis, especially in our children with atopic dermatitis. And then, of course, you can get injection site reactions and pain. That's the most common side effect.
Okay, thank you. And I had a son that was on a biologic for 7 years and no side effects.
Yeah,
Luckily, we
they're
didn't have any side
very
effects.
safe.
Yes, it did keep him out of the hospital. He has severe asthma, so that was a great side effect from my point of view. There's another question here, a little bit long, so hold on with me. I work with parents of children that have severe food allergies, and I also have a child with a severe peanut and dairy allergy. During my pregnancy, I was encouraged to eat peanut butter as the perfect protein and milk and cheese for protein and calcium. I'd like to know the best way to encourage my parents with children that have severe food allergies, how best to protect them from reactions. And that kind of is a little bit what you talked about, not having that fear of food.
How to protect.
Yeah,
So
how it says.
how do parents best protect their children from the reactions?
Mm-hmm.
Yeah, I mean, I think we're left with what we have, identifying what your allergen is and reading food labels and talking to wait staff when you go out to restaurants, talking to family and friends and explaining to them, that this is serious, and trying to figure out what the food is that they're serving that day. So I think you just have to be an advocate all the time, which you already do as a parent anyways, but it's just to the next level with food allergies.
Right, right. And even, when we think about food allergies, a lot of us don't outgrow food allergies. A lot of adults still have food allergies. And one of the things I found helpful is to carry a chef card.
Yeah.
And that's just a little card. And I make sure that it follows, my food all the way through the cook line and through everyone and then back to my table. So no, everyone has seen it. So there's no cross contact for seafood or anything else. So
Mhm.
another tip that could help for the people out there. We have another question that says, when will more of the Dupixent study results be available? We are hoping our son with food allergies and EOE and who is taking Dupixent for EOE will see improvement with both allergic diseases.
I'm not sure. I know the results are pending, but I haven't been involved in the studies. So hopefully within the next, I'd say 6 to 12 months, since the trial, I believe, is over.
Okay, thank you. Another thing I wanted to mention is I know we're talking quite a bit about biologics and we know that they can be expensive. So for any of you that need a biologic, please talk to your doctor about that and make sure that you get the information you need about co-pay assistance. We used that for 7 years for my son. So for most biologics, they can help with co-pays. We know that they can be a little bit hefty sometimes. So please don't let that dissuade you if that's something that you think needs to be part of your care plan. We do have someone that is asking for a link for chef cards. So there's Chris's email is right up there above. If you can send an email to her, and then I will make sure that you get the chef card. And there's a lot of different chef cards that are out on the market. So, and they can usually be personalized to whatever your food allergen is, and they are in different languages as well. So that would be a great option. Dr. Moore, is there anything else that we didn't cover or you can think of that we needed to mention?
No, I don't think so.
I think all the data that you shared with us today is showing that this is absolutely effective. The data is there, this is working, and it may take a little bit of a mindset as well as on the part of insurance companies.
Yeah,
Sometimes that can be a little bit interesting,
right.
but I think this really gives people hope for the future.
I hope
That
so.
there's, yeah, hope out there for food allergies, and I hope your child is better with the little
Thank you.
hit
I'm
to the
going to go
eye.
check it out as soon as I sign off. Get some ice on.
Okay. Thank you, everyone, for joining us for the survey that goes out. Dr. Moore, if you could just go a couple slides forward. There
Sure.
is a survey. Please fill that out. We actually look at every single comment that comes in that. And if you have ideas for a webinar or there's other feedback you'd like, I look at all of those. This is our next webinar, How to Make a House or Apartment Allergy and Asthma Friendly, May 25th, 4 p.m. Eastern Time. Please feel free to register for that. That is not credentialed. It is another one of all of our webinars are free. So please feel free to sign up for that. And thank you again, Dr. Moore, for helping all of the patients and families and clinicians out there that deal with food allergies.
You're welcome. Thank you for having me.
Okay, have a good day, everyone.
Bye.